Hello and welcome to our video, Management of Non-Diabetic Vitreous Hemorrhage in a Young Female. My name is Emmanouil Mavrikakis and I am the Director of the Ophthalmology Department of Genimatas Athens General Hospital in Athens. I have no financial disclosures. A 24-year-old female was referred to our vitreoretinal service due to blurred vision in her right eye for the last 10 days. Her past medical history included hypothyroidism, while her past ophthalmic history, she mentioned history of blurred vision in her right eye 2 months ago, which cleared spontaneously within a week. There was no history of myopia. On examination, visual acuity 612 in the right eye and 66 in the left eye. Anterior segments normal on both eyes. Intraocular pressures within normal limits. Posterior segments in the right eye showed an inferior vitreous hemorrhage, while in the left eye some vitreous traction between 5 and 6 o'clock position. B-scan ultrasound showed flat retina on both eyes with no retinal breaks. She was followed up closely weekly for 1 month with stable clinical picture. 30 days after her first visit, her vision dropped to 6/100 in the right eye due to dense grade 4 vitreous hemorrhage. B-scan ultrasound of the right eye showed no signs of retinal detachment or retinal breaks. The patient was advised to proceed with vitrectomy in order to investigate the reason of the vitreous hemorrhage and also to clear the vitreous hemorrhage. We use a 23 gauge, 10,000 cuts per minute beveled cutter, and we initiate with a core vitrectomy of a dense grade 4 vitreous hemorrhage. And as you can see, the optic nerve and the retinal vessels are not visible. Once the dense vitreous hemorrhage was cleared, our next step is to initiate a posterior vitreous detachment. As you can see here, the PVD is initiated and beautifully shown. And then after completing the PVD creation, we proceed with 360 vitrectomy and clearing the vitreous hemorrhage completely. Intraoperatively, an active bleeding is noticed by a retina vessel at 6 o'clock, which is cauterized by the help of endodiathermy. We then proceed with relieving any vitreoretinal traction with the help of the beveled tip of the 10,000 cuts vitrector, which is used as forceps, as you can beautifully see now. And thus we minimize the chance of further bleeding in the future. We then continue with endolaser on the sensitive areas. However, no breaks or retinal detachment was seen during the 360 scleral depression. As no breaks and detachment was seen, there was no intraocular gas used in this case. Now, with regards to the post-surgery follow-up, day 1, her vision improved and the fundus exam was possible. Day 4, the visual acuity improved to 630 with no vitreous hemorrhage. Month 1, the visual acuity improved to 615, while month 2, the visual acuity improved to 6.9 and remains 6.9 with a beautiful contour of OCT scan of the macula. In conclusion, the surgical management of non-diabetic vitreous hemorrhage continues to evolve as vitrectomy surgery and equipment evolve and become safer, resulting in better postoperative vision and reduced risk of retinal detachment and PVR. I would like to thank you for your attention.